First of all, here's my disclosure. First of all, why we put EpiTer-2? Because, first of all, EpiTer mean epidemiology and therapeutics. EpiTer-1 was the study which we carried out in 29 Polish centers between 2013 and 2015. It was very simple, questionnaire-based study, which provided us information on availability and efficacy and split of genotypes between 2013 and 2015. It was the moment when we still had interferon-based therapy, but some centers had already availability to treat patients with interferon-free regimen. And with this EpiTer-1 study, we got such a nice picture of increasing efficacy of treatment, starting from regular interferon plus ribavirin till interferon-free regimens. So EpiTer-2 is a real-world, I would say even very real-world database of patients treated for HCV in Poland within National Health Fund's reimbursement therapeutic program, which started from mid-2015. It's an independent, initiated and supported by Polish Association of Epidemiologists and Infectiologists study that include 22 HCV treating centers. It's about 1/3 of all treating centers in Poland. But what is important, particularly from the perspective of co-infection conference, that among these 22 centers, 20 were infectious disease. That included 13 which treated not only hepatitis but also HIV. It's some kind of tradition in Poland that anything yellowish was moved to infectious disease. That's why we are all the time treating hepatitis patients. EpiTer started in 2015, and it has three phases. In the first phase, we included almost 3,000. In the second phase, we included more than 3,000. And now, database for 2018 started with October the 1st, and up to now, so within less than 2 weeks, we were able to complete 837 records. It's numbers from today. And I just want to present some numbers, very general data from the EpiTer-2 database, because we were already able to publish 3 articles in good journals, and several others are ongoing. So at this moment, I have only limited time to present general information, focusing on comparison between 2016 and 2017, so how our patients changed. First of all, as you can see, there was no change in gender, more or less half to half, with small predominance of females. If we compare the average age of this population, always, both in 2016 and 2017, females were a little bit older among treated patients, and it's even more visible on these figures. You see, we have some kind of very typical for Poland pattern, 2 peaks. Older patients are in the larger peak, younger in the lower peak, and on the right you always have predominance of females, on the left males. If we compare year by year, it's clear that younger population in 2017 compared to 16 was driven mostly by the left peak, the lower peak, which is increasing. So Genotypes were more or less the same between these 2 years of comparison, with increasing number of genotype 3 patients treated in 2017, just because we waited at the beginning of 2017 for possible access to pangenotypic therapy for genotype 3 patients. In the middle of the year, it became clear that we will still probably have to treat with soft-PEC-RIBA and soft-RIBA, and therefore physicians didn't wait and put those patients on those regimens. Fortunately, in 2018, in mid-2018, we've got both pangenotypic regimens. Fibrosis, of course, changed. It's improved. In 2017, there is much less cirrhotic patient, and if we look into the 2018 data, it's even less, but we're still finding new freshly diagnosed cirrhotics, so there is a lot of work to do. Also, history of previous therapy changed. In 2016, you see less than half of our patients were naive. In 2017, it's 2/3 of them naive population. And what about type of regimen we administered? In 2016, 2/3 of patients received ombitazivir, paritaprevir plus dazabuvir. In 2017, this regimen is still leading, was still leading, but proportion between different regimens became more equal. Additionally, we receive grazoprevir, elbasvir, so 3 major regimens, but you can see that still 10% were treated with soft-PEC-RIBA or soft-RIBA. Duration of treatment, of course, changed. In 2016, very few patients has access to 8 weeks therapy. In 2017, 12% already received such therapy. But just presenting my center, you can see that in 2017 it was much more than in whole country, 26%, and in this year, up to now, almost half of patients receive 8 weeks regimen. Of course, it's caused by less advanced patients and availability of new labels for Vichirax-Xvira and Harvoni. So what was efficacy? And this data respond to demand addressed by Professor Ferenczi to rely on real numbers. So it's very real numbers. In 2016 and 17, you see we were able to start 6,228 patients, and follow-up was completed in all of them except 14, in which we still are waiting if we got SVR data for them. So altogether almost 100%. And therapeutic success was achieved in 95% with these different regimens, including suboptimal regimens. Treatment failure was in 3% and loss to follow-up in 2%, which in my opinion is excellent result if we look into real-world database. And based on this data, we can say that SVR analysis by intent to treat analysis is 95%, modified intent to treat, so after exclusion of loss to follow-up, 97% of patients which were cured. SVR by fibrosis and genotypes clearly demonstrate where these non-responders. It was genotype 3 and mostly cirrhotics. Other genotypes, even if cirrhotics, achieve excellent SVR rate on the level similar to clinical trials with direct-acting antivirals. Comparing year to year, We don't see a specific difference between regimens. Of course, the best efficacy was achieved with ombitazvir, paritaprevir, dazabuvir, and sofosbuvir, ledipasvir. And you see that the worst was sofosbuvir plus ribavirin, which was mostly administered to cirrhotics with genotype 3. Interestingly, you see that we have a nice number of patients who achieve very exotic regimen of asunaprevir plus daclatazvir, of course with a relatively low efficacy. But also, interestingly, returning, you see sofosbuvir plus pegylated interferon and ribavirin therapy with really excellent efficacy. And these data were published very recently this year. So what about safety? Our database is simple to work on, but contain a lot of data, a lot of questions which have to be answered by people who entering data. But finally, we can provide also safety information. Therapy discontinuation affected only a little bit more than 2% of patients. So, and majority of those patients discontinued within initial 4 weeks of treatment. And the major reason of discontinuation was anemia, and we can understand that those patients who were discontinued mostly discontinued due to ribavirin administration. Very few patients, only 23 among these more than 6,000, died during the treatment and follow-up period. And in the study in cirrhotics infected with genotype 1, we were able also to follow discontinuation rate among those who demonstrated adverse event. And once again, the rate is very low, just 3%. And once again, anemia was major. And you see in this cirrhotic population, which included more than 1,000 patients, the only significant value was related to anemia in population which received ribavirin. We also were able to collect data of 31 patients which was initially treated with interferon-free regimen and didn't respond, and finally were retreated also with interferon-free regimen, but genotype specific, just because we didn't have access to pangenotypic therapies, which could be treated as rescue therapies. But interestingly, even using the genotype-specific regimens, we were able to achieve, particularly it's important in this population, yes, those who completed primary therapy, failed due to virologic reason, efficacy was a little less than 80%. So somebody can say it's not enough, but what we could do if without pangenotypic rescue therapy, and 78% in modified intent to treat analysis, in my opinion, is not bad. This conference is focused, of course, on co-infections. So, of course, we have a lot of co-infected patients, both HIV and HBV co-infected. And in 2016, proportion of HIV co-infected was just 1.4%. And I show you later why. And in 2017, it was 3.9%. Altogether, it was 173 patients. If we look first for hepatitis B co-infection, then numbers are much bigger. You see almost more than 13% of our patients demonstrated any serological signs of co-infection. What is important, HBs antigen testing in Poland is mandatory, so all these patients were tested for HBs antigen, otherwise therapy would not be reimbursed. And among this large population, only 3 cases of HBV reactivation was documented, and 1 case only with elevated aminotransferases. All 3 cases were HBs antigen positive. That's why in Polish guidelines for both hepatitis B and C therapy, we do not consider HBs anti-HBC positive patients as those who are at risk for reactivation. Only patients who are HBs antigen positive or anti-HBC positive but immunodeficient are considered as in risk for possible reactivation. If we compare data available in publication on risk of reactivation in anti-HBC isolated cases, so HBs antigen negative, you see that our data, even if yet not published, are the largest. And all these publications demonstrate 0 on the side of number of reactivations. So what about co-infection with HIV? This curve, this figure is a repetition of the initial picture of age distribution with these 2 peaks in younger population and older. And we can compare age distribution among co-infected population. And you see that a large majority of those who are co-infected are in this lower left side young peak of age. The reason is simple. The time when those people were infected is most likely the period of so-called Polish heroin fashion, which was in 90s until 2000. And that's why about 10% of people in the age between 25 and 50 are co-infected. What about fibrosis in different co-infection population? The largest proportion of cirrhotics is in the group of HCV-HBV co-infected. You see more than 40% of these patients were cirrhotics, but interestingly, in opposite to many publications, in our experience, we don't see high proportion of cirrhotics among HIV co-infected. And it was the reason why in 2016 there was much less patients treated than in 2017, just because priority was given to the most advanced patients. And nobody can say that we didn't want to enroll patients for treatment, because as I mentioned at the beginning, majority of centers involved in EpiTer study were centers for treating both hepatitis and HIV. Of course, among co-infected, there was much more naive patients. And if we look on the overall characteristic of all HCV population and co-infected populations, it's clear that taking into consideration the compensation history, hepatocellular carcinoma history, transplantation history, esophageal varices history, ascites and at baseline, and encephalopathy, other accompanying diseases, kidney insufficiency, MELD score, child pure above A, co-infected patients demonstrated less complicated disease. And what was efficacy? Let's look for modified intent to treat analysis only, these brown bars, and you see that there is no difference between HCV mono-infected and co-infected population, 97–96%. And if we look by genotypes, there is also no specific differences. Of course, intent to treat analysis in co-infected demonstrate a little bit lower efficacy just because we lose some patients due to lower adherence among drug users because some of those patients co-infected were, a large proportion of these patients were current or past drug users. So concluding, patients treated in 2017 compared to 2016 are younger, less fibrotic, and more treatment naive. Efficacy was constantly high, except genotype 3 infected cirrhotics, which will probably be improved in 2018 with access to pangenotypic regimens. And HIV co-infected patients are younger, more frequently treatment naive, and less fibrotic than HCV mono-infected. Efficacy of therapy is similar to HCV mono-infected population, so it's in line with current guidelines of EASL that saying there should be no differentiation between a regular population of HCV infected and HIV co-infected. Thank you very much.